باسمة الدليغان دكتورة باسمة غنية عن التعريف أكيد طبعا، بس يعني لازم نعطيها شوية من حقها زي ما بيقولوا. دكتورة باسمة طبعا she has a doctor of optometry from New England College of Optometry ببوسطن. She also has a subspecialty in cornea and contact lenses from Michigan College of Optometry. She's also American board certified and licensed. She has been recently appointed as one of the members of the board of directors of Saudi Society of Optometry, so congratulations. She used to represent EMCO to the WCO Public Health Committee. Tonight, she's going to talk about RGP lenses for irregular cornea. And if I ever have a patient in Saudi Arabia, I would definitely trust that patient in her hands. Thank you, Dr. Bassima. The platform is yours.
Thank you so much. Thank you for the great introduction. I'm very happy with this introduction. First of all, good evening, everybody. I see that we have about 132 attendees, and that is great. I would like to thank you for sparing the time in your weekend and coming in to attend our presentation. I'll try to make it as interesting as possible. I'll try to make it as short as possible to let you go. And it's really my pleasure to be here. Thank you, Eye Care Association. Thank you, EMCO, for inviting me. Let's go ahead and start our share screen. Okay, start here. Okay, so are you getting a full screen or are you getting a presenter screen? What is the...
It's a full screen, ma'am.
It's a full screen, great. All right, so you're not getting any presenter view, just a full screen, right? Okay, all right, so let's start talking about RGP lenses for irregular cornea. In this presentation, I tried to make it as straightforward as possible because it's a very big group of people and I don't know what is the level of education and contact lenses that they have. So I tried to, sorry, I'm trying to get rid of this. So I try to make it as simple as possible, and it will be great to have any questions at the end of the presentation. It will be my pleasure to answer them. So I just wanted to tell you that mainly we're going to be focusing about keratoconus fitting because this is what is the most prevalent disease in corneal irregularities in our part of the world, in the Middle East. And of course, there are different levels of keratoconus. You see it in our country, and we just need to know how we can get them the best vision possible. These patients are suffering from poor vision, and with a pair of lenses, you can restore their vision, give them a great life, give them a normal life, and reduce their suffering. So how to fit a keratoconus patient? Well, there is no really one approach to fitting a keratoconus patient. You have to know that there's no one lens for everybody, okay? It doesn't fit all cases of keratoconus. You need to treat each case differently based on the severity of the case, based on the lifestyle, based if it's a monocular or binocular keratoconus, or the problems is in both eyes. So this is what you need to put in mind when you start fitting. So how to diagnose keratoconus? Basically, there are so many ways of doing it, but let's say that you're working in a rural area where you don't have a lot of instruments in your clinic, and you need to detect this disease as early as possible to save the patient a long journey of suffering from being in an advanced situation. If you're working in a busy practice, I'm sure you're gonna run by 1 or 2 keratoconus patients a day, and that what makes it really our job is very interesting. So it's your part, and it's your job to pick it up. There are very simple things that while you're doing your refraction, for example, you just grab your retinoscope and you start doing your retinoscopy. So if you see the scissoring motion reflex while doing the retinoscopy, where the reflex really splits while you are moving your streak right and left, then you know that this patient has some kind of irregularities in his cornea, and that's your first early sign of keratoconus. If you're using just an auto ref and you don't have a retinoscope, then just looking at the placido disc Myers on that reflects on the cornea, you'll be able to see those distorted or oval Myers, and definitely that is a keratoconus patient. So this is what you need to look at when you are detect keratoconus. Also, if you do have a slit lamp, then there is a much more advanced or more things that you can see using your slit lamp by looking at the Fleischer ring, where some iron deposits can accumulate in the basal epithelial cells around the base of the cone. Stress lines that you found them in Descemet's membrane, we call it Vaught's stria. Also, this is also a very clear sign. Of course, if you start seeing Munson sign, then you are pretty much dealing with a very advanced case of keratoconus. Thinning and scarring. We know that the disease of keratoconus is mainly happens to the stroma, where the thinning happens in the stroma, and this is where the scarring occurs. If you are still not sure, listen to what the patient tells you. Just focus on what they say, on their symptoms. So if you notice that, for example, that the patient is having a frequent changes in their spectacles. So for example, you did the refraction 3 months ago and you give them the prescription, and after 3 months, they would come to you saying that this prescription is no good anymore. And I would like to check my vision again. And then you discovered that they have a totally different prescription. This is your first clue that this patient is having keratoconus, and actually he's progressing. So the change in refractive error, that means he's progressing. So this is where you have to catch him early, and we're going to talk more about what you can do for him first. High cylinder in an oblique axis, the poor endpoint of best corrected vision. So you're doing your best, you're doing refraction and subjective and trying your best to give him the best glasses possible, but he can't, see more than 20/40 or 20/50, then probably it's not your fault. It's probably he has keratoconus, and especially if you run a pinhole in front of them, they will definitely see better. If they say, I see ghost images, like light bursts, if I see worse at night than in the morning, this is all your signs. Just pay attention to them. And the hallmark for keratoconus is the severely squinting eyes, like as if they're creating their own pinhole in order to see better. So most cases of keratoconus, just so you know, it's discovered or diagnosed or detected by optometrists. So pay attention to that. So this is just a classification. If you have a corneal topographer, this is the classification of the mild, moderate, and advanced severe cases. So when I said that you need to catch those patients early, because of the main important things that we are doing right now is to send them to do cross-linking. Sending them to cross-linking, you are stiffening their cornea, you're trying to halt the progression of the disease, not to make it getting any worse or something like that. So catching them when they're mild, around 45, 50 diopters, that will be really great, because the minute the progression stops at this level, you can get away with glasses, you can get away with soft contact lenses, you can get away with things, a part-time use of contact lenses, because let's be honest, contact lens can be it can be hard for some patients, overwhelming for other people. Some people, they would go to surgery just not to use contact lenses. So catch them early, and that will be a great thing you did. So what does the patient who's using contact lenses actually want when he's doing when he's using his contact lenses? As we said, we want good vision, all day comfort, and healthy eyes. So good vision, you do them by doing a great fitting and a good power and choosing a good power. And definitely also the comfort happens when you are fitting him with the most appropriate contact lens that fits his keratoconus or his cornea. And definitely you need to make sure that the lens that you're prescribing is not causing any harm to the patient. You're not pushing too much on the cornea, you're not putting too much stress on the cornea to cause any scars. There's no rubbing on the eyelids, continuous rubbing. You're making sure that the patient is using the contact lens in the correct way, giving them the right contact lens hygiene and care. All of these things you need to run them by the patient to make sure that they don't go into any complications of contact lenses. I'm not going to really talk about this, but case history is very important. When in my first encounter with the patient, I try to really understand what is their experience before, their previous correction, what are they doing, what they have been using before. All of these things really direct me to where I'm going and what I'm going to prescribe. So if a patient comes to me and he says that the minute I tell him I would like to fit you with an RGP lens, and then I get this a very resistant and a very angry look from the patient, is like, no, I've tried it before, they're really bad, they hurt my eye, I don't want to try them again. And I just tell them, please do not keep your previous bad experience affecting your future, because definitely there are much better options in the market than the things that you used before. So try to understand what's the patient, what's his fear, what he went through, what is actually really bothered him when using contact lenses before. You need to understand if they are progressing or stable, and that would be through looking at old corneal topographers. And this is what I always ask our receptionists to tell the patient: if you have any previous printouts or even in your phone or anything like this of a previous corneal topographer, please bring them with you, because I am going to run a new topographer in that day, at the day of the visit, and I'm going to compare. If I see any progression, definitely the first step I'm going to do is just send them to cross-linking. Age is very important, because the younger the patient, if the disease happens at a younger age, the more advanced that they will end up with a very severe case of keratoconus. So when we're talking about 15 to 20 years old, these patients need to be sent to cross-linking before even starting the fitting. Same thing for in their 20s, early 30s. Some people who would come to my clinic for the first time in their over 30s, I would just tell them, well, you can do cross-linking, or I can monitor you doing topography every 6 months just to see if there is any changes, then we can make the decision. But this critical age from 15 to 30 is, I really, really strongly advise that they would do cross-linking even before fitting them with contact lenses. So they would do the cross-linking today, 2 months later, I can do the fitting when everything is healed and the corneal haze has reduced and all of these things. I need to understand what kind of work, job, sports they do, because that really affects my decision too. If a patient is very active, he's into sports, he's a patient who works in a dry environment where there's a lot of air currents, hot climates, all of these things I need to understand, because going with a smaller diameter contact lens might not be the good option. You need to go with something that is more stable. You need to go with something that it doesn't dislodge easily, or get bothered by like dusty weather, like the weather that we have in our countries, or very windy weather. So all of these things, just put them at the back of your head before making your decision. Okay, I need topography. Without topography, I don't work. Well, never. Because, all right, let me look at your severity. Let me look at the location of the cone. Let me look at the shape. And I look at the patient's eye. I need to see how their eye fissure, their eye opening, all of this thing, again, all of this thing will direct you where you're going, this way, that way, or that way. We need to document. We need to document everything in our first visit. If there's any scarring, you just need to know, did you cause the scarring or that was there before? So everything needs to be documented perfectly. Dry eyes, I always like if I see that the patient is really suffering from severe dryness, I try to do the fitting and then tell them that the lenses are going to take about a month to arrive. During this month, please try to increase your lubrication, try to heal the reason for your dry eyes, use hot compresses, do anything that really heals your dry eye. If I see any staining, any old scar, negative staining, all of these things that needs to be documented. If there is an allergy, you need to treat this allergy before even considering prescribing contact lenses, because allergy and contact lenses is the really enemy of our allergies are the enemy for contact lenses. They will not feel comfortable wearing them. It will cause them a lot of troubles. Look at the eyelids. Avert the lid, make sure there's no papilla or any follicles that will rub against those lenses. This is what you just do in your first examination before fitting the patient, that you need to focus on these things. So I'm going to do the classification part of keratoconus, and the reason for that, I would like to tell you what is the most recommended contact lenses for each case. So if I see a nipple cone, which is a very small near central ectasia that it flattens rapidly from the top of the cone until the base of the cone. So when you are dealing with a very rapid change in the curvature of the cone, you need to know what is the best contact lenses to contour, to follow the contour or the shape of the cornea. The lenses to consider when you're having nipple cone, if you are going to go with a smaller diameter RGP lenses, or what we call them corneal RGP lenses, you need to think about something that is not more than 9 millimeter. So an 8.5 would be a great diameter for this type of cone. I would love to talk more about each one, but just briefly, we're going to talk about piggyback. Piggyback and corneal RGP, they are absolutely a wonderful option for some people. So basically you put a soft lens as a cushion to protect this very fragile, very thin advanced cone before adding or putting your corneal RGP on top of it. And scleral lenses, this is my really lens of choice for most of the cases, but I still do other types of lenses. It's still there. I still fit them. Some patients, they come and ask for them specifically because they're used to them. We've been using corneal RGP lenses for many tens of years, for many years. And some patients, they just don't like to learn a new thing or break their habits. They just want to continue the way they are. So corneal RGP is something that you need to always learn and consider. Now, if you're dealing with a more inferior cone and an oval cone, things get a little bit more challenging, okay? Because with the corneal RGP lenses, they will not stay in the center. Their centration is going to be so poor with corneal lenses. So you need, if you're going to go with corneal lenses, you need to choose something that is a little bit larger in diameter. And something around 9.5, 10.5 corneal RGP would do the job. Hybrid lenses is an option, and scleral lenses again is an option. Now, if you're dealing with a case of keratoglobus, and this is the nightmare of every optometrist, you really don't want to see this case in your chair. However, they are there. Thank God they're not many, but they are there. So, so basically all the cornea is bulging out. Everything is really protruded. So basically there is no much choices for these patients. You only have the scleral lenses and not any scleral. You need to go with the large diameter scleral lenses. And we're going to talk more about it now. Lucid is also some type of an inferiorly displaced cone, has a very unique shape, but this is also something that you can use either a reverse geometry corneal RGP lenses, hybrid lenses, or again, scleral lenses. So you will see me saying scleral lenses in every single slide because it is the most widely used lens these days. Again, same thing for post-LASIK ectasia, and to be like surprisingly, I am still seeing until this day patients who had an RK, the radial keratotomy refractive surgery. So we're talking about this procedure has been disconnected, so stopped, or the stopped being operated on since like what, more than 30 years maybe, since lasers and LASIKs have been there. But until now, there are some patients who come to me with those RK incisions and scarring and a very flat central cornea with a very irregular shaped cornea. Again, for those patients, I believe nothing works with them better than sclerals. So this is just a quick classification of the diameters that you have for corneal lenses. Your diameter ranges from 8 to 11.5, so we're still within the corneal size. Scleral lenses also have different diameters. Hybrid lenses have one diameter. I mean, it's a fixed diameter, and then there is the option of using soft lenses for keratoconus. So just if you do have trial lenses of all of these types of lenses, then you can do miracles. So what I want you to do, I want you to be confident. If you want to start fitting corneal lenses, if you want to start fitting lenses, go ahead and get your trial sets and start. Read a lot in the literature. Make sure that you want to go this pathway, you can learn it. It takes a learning curve. It takes some time to get the hang of it. But attend courses, read the journals, all of that will help you a lot. When a patient comes to me and then they would tell me that, why don't I go for surgery instead of using those contact lenses and get into the hassle of contact lenses, I would tell them that contact lenses is the less risky, least cost of all the other surgical options. And I don't know, you need to get them away from surgeries. I mean, I know ophthalmologists are not going to be happy with that, but contact lenses can really save them from going into any major surgeries. I'm talking about really major surgeries like transplants, like all of these things. But yeah, you can do. Build a good rapport with your patients because they will be so loyal to you. They will come to you. I've been seeing patients since 10 years ago. They've been always there with me, and this is how you really get more confident. Let's start with corneal lenses. We'll talk more about it. So again, I think of corneal RGP lenses when I have nipple cone, oval cone, or moderate irregularities. So disadvantage of those lenses, they can cause staining and scarring if they're fitted wrong. So I know the old approach, and if there is any people from the old school listening to me, they would know what I'm talking about. Before, they used to tell the patient, or they used to think that pushing on the cornea with the RGP lens really actually stops the progression of the disease. And that is absolutely wrong because it only causes scarring and more problems. The corneal lenses can dislodge easily if you fit it a little bit flatter, or if the patient has a really active life. This can cause the lens to pop out of the eye. Also, these lenses can trap foreign bodies, dust. If it's really windy, it bothers the patients a lot. They can't open their eyes. They don't feel comfortable when it's really windy or dusty. And they tend to decenter a lot to the inferior part, especially with inferiorly displaced cones. So these are the disadvantages of lenses. However, the advantages this is just the approach of fitting or the ideal fitting of a corneal RGP. You need to make it a feather touch. You have a paracentral clearance. You need to have a mid-peripheral, very, very light touch. So something that looks like this is actually very, very ideal fit. So adequate edge lift, all of these things. Now, if you do fit those lenses in a flatter way and like an apical touch, as I said before, that was the approach, you're going to end up with a heavy, strong central scarring. And I believe you can see the scarring showing actually right here. You can see somehow all the scarring that is occurring right here. So this is the disadvantages of fitting those patients with a flat fit. There is only one advantage of doing that approach, which is it gives better vision because as a result of this apical bearing. And this is one of the things I also face in clinic. Patients come with me with this looking lenses. And I would never leave any patient looking like that and leaving them in this situation. So when I fit them with the steeper lenses, immediately the vision will drop a little bit. And because of dropping this vision, because I'm not pushing too much on the cornea anymore, and this is when the patient comes a little bit frustrated and not very happy with the new lenses. And I explain to them that this is what we have to do. So don't do that for sure. Again, don't fit too steep, because if you fit too steep, or if you use a large diameter on a nipple cone or on a smaller cone, you're gonna end up with sealing of the lenses like this. You're gonna have a very heavy bearing right in the center, or a very with a lot of pooling around the cone, and this is actually a very not comfortable fit or for the patient if you really have those lenses stuck on very harsh on the eye. So my advice to you, do not use corneal lenses in cases that looks like this. You see this kind of irregularities, it's very severe, very severe. Let me show you here how we're reaching up to 73 steepness. The steepest area here is about 73. So what kind of corneal lenses can sit on this eye? That's definitely not an option. Don't use this as severe irregularities, very decentered cones. Definitely all of this is not a RGP options. So if you decided to fit hybrid lenses, it's also a great option. You get the comfort of having a soft lens part, the soft lens part, and you get the vision of an RGP part, and it's a hybrid lens. So you get soft and hard lenses in the same time. It's a great replacement for people who used to, and you will be surprised, I swear to God, I know some people, maybe I haven't seen anything in the past 1 or 2 years, but just 2 years ago, I used to have people who still using the soft curve. They kept it all this time with them, and they're still using them. And thank God those lenses have stopped. So it's a great replacement for those patients who had this experience before the soft perm. You need to have a complete central apical clearance with this, with those lenses. You need to have a beautiful thinning around this area where between the RGP border and the soft skirt, we call it the soft skirt. You need to have a nice thinning, and then you need to have a very good bearing of the soft lens. I hear some noise coming in. Do you guys hear it? Do you hear those, Dr. Yazan, do you hear this kind of noise coming in the background? Okay. Right, let's continue. So when it comes to hybrid lenses, There are two generations of hybrid lenses. It started with something, I'm going to talk about a specific brand. I'm going to talk about the Synergize brand, which is the clear cone. That's the first generation. And the second generation is called the Ultra Health. There's a very big advantage shifting from the older design or the older generation to the second generation, where there's an improved oxygen transmissibility of the RGP lens and of the soft skirt lens, because whatever complications we used to have with the clear cone, it actually disappeared by using the Ultra Health design. Soft lenses for keratoconus is also another option. You try to use them for earlier to moderate cases. I use them for patients who would never be able to insert an RGP lens for them, even if the vision is not the greatest, but I try to it has to be there in my cabinet. I use it in many cases. Basically, it's a soft lens. It's a little bit thicker lens, creates a thicker tear lens, so it kind of masks of some of the irregularities of the cornea, and that will provide them with a better vision. So again, it's not a choice for advanced cases or very severe cases. I use them only mild to moderate cases of keratoconus, especially, and that's very important to focus on, especially with the ones that they have good spectacle vision. So once I see the patient, some keratoconus patients, they would come and they see 20/20 with their glasses. However, they suffer from some reduced vision at night. They suffer from not seeing well, having those light bursts and stuff like this. This could be a very good option for them. There has been a study in 2006 where they got 88 keratoconus eyes, ranging from mild to advanced. These eyes were grouped as follows. So 15% were early, 53% was moderate, and only 26 advanced, 5 were severe. The results showed that 91% of the eyes achieved visual acuity better than 20/40. So this is what I'm saying. Even if the vision is not optimal, sometimes using this easy modality for some difficult patients, some patients are super difficult. They would never be able to put in RGP lenses, so consider this type of lenses for those cases. All right, when it comes to scleral lenses, always really a great option for everybody. It's a large diameter RGP lens. It has very much less movement. So that means that it guarantees better comfort, and it's definitely an RGP lenses, so great vision. There is no upper eyelid interaction with those lenses. They're very stable. They're very comfortable in the eye. So definitely changed lives of many contact lens users, and the results were amazing. We're gonna go talk more about it. So just understand what they do is that those lenses, they never touch the cornea. They have to have some clearance, a very good clearance between the lens and the cornea. And we prescribe them based on the sagittal depth. Okay, so we look at the cornea as a mountain. We don't look at it as how deep, or we don't look at the curvature of the cornea. We look about the sagittal height of the lenses. And the topographical map of choice really helps us a lot with this kind of choosing those kind of lenses is actually the posterior float lenses. So the elevation map, and the elevation map will give you exactly how elevated or how those lenses, how those corneas are high or low. So I use them for mainly all of these cases, starting from mild to very advanced to severe cases, and work perfectly. So with those lenses, make sure you have to avoid something called central corneal bearing. So anything that looks like this, it's a big no-no. especially with lenses. Anyway, the minute you insert a lens like this in the patient's eye, he will tell you that those lenses are not comfortable at all. So you cannot prescribe those lenses for those patients at all. You need to avoid something called limbal bearing. You need to make sure you don't impinge the conjunctival vessels. If you avoid all these three things, then you are doing a good job. You are looking at an ideal fit that looks like that, where you have a beautiful, let me use the laser again, where you have a beautiful layers of clearance in the center, and then it gradually goes down until the limbal area, and then there's a beautiful alignment of the sclera haptics, sclera lens haptics over the conjunctival, or the sclera. So if you want to start fitting those lenses, you need to see what is available in your country, obviously. To make your life a little bit easier, you need to start with the simpler designs. Spherical periphery, for example, you can choose the lenses that, the designs that works with software calculators, easy to order through your agent, to the agents who provide trial sets for you. So these probably some of the tips or advices that I can tell you if you want to really start fitting scleral lenses. But how do we do it? Look at the corneal topography, as I said, the elevation map. And if you have no clue where to start and you don't know what to do, you can just pick the lens in the middle of the trial set. I usually look at the gross looking, I look at the cornea in a gross view. I look how protruded the cornea is. And based on that, I'm looking at the elevation map, of course, I can pick the lens based on the severity of the cases. So let's say you're using a 15 diameter scleral lenses, and for early cases, not very advanced cases, the early cases, you can choose some sagittal height or sagittal depth lenses around 3,000 or 4,000 microns. If you are talking about more moderate, you can use the 4,000, the 4,500 microns. So that's in case if you don't know what to do, you can start with this range. And every scleral lenses, they have a fitting guide in it. They will tell you what is the recommended lenses to begin with. So you need to put something in the eye, basically. If you put something in the eye, then you know where to go from there. If you're using a 60 millimeter diameter, then you're talking about more deeper lenses. So we're talking about 5,000, 5,500. Severe cases, they are the cases about 5,000 to 5,500 to 6,000 microns. And in really, really advanced cases, then we are talking about, you need to look for something around 6,000 and more. So as I said earlier, if you're not sure, just pick the lens in the middle of the trial set and put it in the eye. Once you place it, there are two things to look at. Is there a bubble? That's the first question. So is it looking like that? Is there a clear, obvious insertion bubble? If you see that, you need to remove the lenses right away, fill them up again, and then put them back in the eye. And if you put them on and you see a touch that looks like that, definitely move them and go immediately about 250 microns deeper. So once you put your lens on and you think it's a good fit, there's no bubble, there's no touch, start evaluating the central clearance of the lenses. So what you do is that you grab your slit beam, and then you look at this green, and then of course you fill it up with saline, put some fluorescein in the middle of the ball, and then when you insert it, you're gonna look and use your white light at this point, and then you can look at the central clearance. So we're talking here about a central, oh, you have to choose the magnifying lens. So here the best way of knowing exactly what is going on in this area is actually to compare it to the thickness of the lens you're using. So you compare this this layer to this layer. I'm not very sure it's very clear to you, but this is where the lens material is. Actually, this is the lens reservoir, and then this is the cornea. Okay, so we need, let's say you're using a 300 micron lenses. For example, if you use the 300 micron lenses, then this is looks like similar to this thickness. The thickness here is similar to this, the thickness here. So I think you are within a 300, 350 microns in this central area. So you're good to go. You leave it this way. Now move and scan across the cornea. Just scan across the cornea from here, going this way and going this way, flipping the arm to the other side and looking at the streak right here and right here. You should see a gradual decrease in the sagittal height from the center as you go on to the periphery. So once you reach to the limbal area, once you put your light in this limbal area right here, you are looking for something around 80 to 100 microns of clearance, not more than that. And then you need to evaluate the scleral edge haptics. So looking at the vessels, follow the vessels, so you can basically have a very good understanding. So if you see those vessels, they look fine. There's nothing pressing on them. There's no impingement, so that there's no lift off. So all of these things that will tell you that those scleral haptics are pretty much aligned with the conjunctiva. So you are in the good shape. Ask the patient to look left, right, up and down to make sure those lenses are doing well. Of course, you need to leave those lenses to settle down a little bit before you make your decision. If you really don't have the time for that, I advise you to do that, especially if you're not an experienced contact lens fitter. You need to leave the lens at least for 30 minutes or like 45 minutes before really evaluating those lenses. But if you don't have the time and you're really in a busy practice, you cannot wait 45 minutes for each patient, you can leave a leverage, leave a little bit of more areas for those lenses to settle down after a while, because as we know, those are really heavy lenses and they will settle down with time and they will sit closer to the conjunctiva, because the conjunctiva is a spongy tissue. It will allow it to settle down and sit more down, and that can really change your central clearance dramatically. So the dropping or the dropping of the lenses, it could go from like 100 to 150, sometimes 200 microns of less clearance you get with time. So you just need to make sure that you already left a good room for those lenses to settle. Again, those, I just wanted to talk about these calculators because I find them so helpful. And, you know, I spent so much time with those calculators, more than the fitting time actually. So it cuts down my changes time. So you can just put whatever parameters you put in here with your trial lens, and then you can add what is your final parameters and what are the changes that you're looking for in these areas. So if the sagittal height you're using is 4,500 and you need more, you tell them, hey, why don't you add another 200 microns? So you write 4,700 microns here. You put your over-refraction here and you just press the word calculate and we'll tell you exactly what is your the lens of choice. All right, I'm about to finish. It's just a beautiful study that I wanted to run by you. It's a questionnaire that was given to contact lens fitter on the trends of fitting RGP modalities. And last 100 foot for each, for the people who did the survey or the questionnaire, they give us the percentage of what they use, and scleral lenses was the highest of them all. And the next, the corneal RGP, the intralimbal lenses, specialty soft lenses, hybrid, piggyback. So again, this wins, the scleral lenses, they win. These are my references for everything we talked about, and I think it's about time to get some questions and answers. And I hope you guys really benefited from what I said, and I believe the question and answer session will let us talk more about those about the subject. So I am done.
Indeed. Thank you, Dr. Bassima. And I asked everybody just to keep on mute and post their questions on the chat box so that it will be much easier for all of us. I haven't received many questions yet, but if you allow me, first of all, to ask in the Global Specialty Lens Symposium, which happened in January, they were recommending not to wait that long after cross-linking to do scleral. They just said, like, wait for a month and you can do that. Do you think is that practical? Is that fine?
Yeah, well, you need to have a complete healing. And you need those haze to reduce. So if the patient is not suffering from any haze, go ahead and do it. And it's completely healed. They are done with their medication. They're not using any more steroidal lens drops or any antibiotics or anything like that. And there is no much haze, because haze is going to reduce your vision a little bit. So you just want to get what is the best corrected vision you can get with those lenses. So I tell them 4 to 6 weeks is ideal. If there's any complications after cross-linking, then you have to wait about 2 months. So yeah.
Good. Excellent. There was a question about if the cause of keratoconus is oxidative stress, and there's so much metabolic waste and these things. Do you think we as optoms should prescribe like those nutrients or antioxidants, or it wouldn't be in our scope of practice?
Well, I mean, so far we cannot prescribe less than that in our countries. I believe no, it has to be under the, so far it has to be under ophthalmology supervision. I haven't seen any optometrists doing that in my area. No.
All right. For those who wish to work in Saudi Arabia or simply come and do some training, are there any training facilities? Do you provide such facility yourself? Or are you aware of something?
Out of Saudi Arabia, you mean?
Out of Saudi Arabia, yeah, I know it's an interesting question. So
yeah. So far, I don't think any contact lens training program happening for people from outside Arabia. We do have our eye hospital that gives contact lens training for people from employees of other hospitals. So if this hospital wants to have a contact lens practitioner having some training, they would send them to our eye hospital where they can get this. But there is no, I don't know if there is anything public. No, I don't think so.
I think I can answer this question. Dubai is very close to Saudi Arabia, I guess. And if you remember our colleague, Dadi Fadel from Italy, who was originally from Lebanon, I talked to her last week. She's planning to conduct a 2-day workshop in Dubai. She didn't tell me the details yet, but I think that might be a viable option for some of our colleagues in the Gulf region, right?
I'm sorry, say that again. Go ahead.
Dadi Fadel told me that she will be conducting a 2-day workshop in Dubai about fitting KC with scleral lenses. So that might be an option for some of the guys, right?
For people who, yeah, I mean, Dubai is a easy access for many people. And you remember, Dr. Yazan, we used to do a lot of training courses there in Dubai. But what training courses that is more than 3 days, 1 week is really beneficial. But something that is like 1 day, if you are going to do a 1-day training or a 2-day training, I believe it has to be from 8 to 5, where you have a hands-on training, where you see different patients. It has to be seeing an actual keratoconus patient, not just doing it in a theoretical part or talking about just cases that you've seen yourself. No, and basically you need it to be a really certified course. So it's kind of it needs to be more time, because contact lens practice is all about expertise. It's about the more you spend fitting those patients and the more cases you see, the more you learn. So learning curves comes with time. And as I said in the beginning, reading journals, attending courses, there's a lot of online courses also, but again, a hands-on training is what's going to it will make you a skilled contact lens fitter.
Indeed, and be a good friend with the contact lens distributors. They know a lot and they can help you a lot, I guess, right?
Yeah, they do. A lot of them they can do, yes.
Hopefully. You mentioned squinting. We usually think about it when we are myopic and we just want to have a pinhole effect. What about KC? Do they usually squint? That's one of the questions that I heard. All the time, sometimes. Can you illuminate on this point, please?
Well, the squinting with myopia, it's this much. For example, the squinting with keratoconus is this much. Okay, they squint hardly with all their powers, seriously, and I have seen them. They would be opening their eyes in a split of the second. If they want to see something, they just squint really hard, where they almost having a real pinhole. So yeah, and for myopia, they do the same, except depending on the degree of myopia, the squinting, you know, it could be really small squinting or a big squint. So yes, those patients, I swear to God, I can tell keratoconus patients from across the room. They have these glittery, sparkly corneas that you can see. And the minute you see them squinting, I've stopped many people in the streets telling them, you do have a corneal issue and you need to be seen because of this very, very clear glistening of their cornea. So yeah, I mean, this is what this is what they suffer from.
I know you didn't mention local anesthetics, but one of the attendees here asked, do you usually use it all the time? Sometimes you prefer not to use it. What do you think when fitting RGPs?
Never
right?
Use anesthetic. Actually, I'll tell you the classical scenario, the classical story that every patient, they come to me and they say, doctor, I went to this X clinic and they fit me with lenses, and during the fit I was very happy and I didn't feel anything and I saw very well. That's why I ran and got these lenses. I bought them, I purchased them, and the minute I tried to put them at home, it was like putting a piece of rock in my eye, or I couldn't really tolerate them or something like this. I need to get the feedback from the patient when I put the lens on. That is like very important. Is it comfortable? Do you feel anything? It changes my decision with those lenses dramatically. So the minute the patient tells me, even with scleral lenses, if not fitted well, they can be sometimes uncomfortable. Indeed. So how's the lenses are feeling? So I give them about, of course, the first 5 minutes for a patient who never used a contact lens before, they will have this awareness, the mild sensation of the lenses. But then after like 5-10 minutes of the examination, I started asking them, how is it feeling? How is it comfortable? How's it going on? And the minute they say it feels good, however, I feel like it's kind of like hitting my eyelid, especially and they start pointing here, here, here. I grab my slit lamp and I look at it, and yes, there is an edge lift in this area, or this edge in this area, and exactly that's why you need to hear their feedback. So if I see, for example, a lift in a certain area, I go with the quadrant specific lenses. I do toric peripheries. I try to fit it so it can be as equal as possible in all quadrants of the sclera. Again, a poorly fitted scleral lenses sometimes can be really comfortable, even if it's poorly fitted. So you need to just be careful. Like I've seen cases where patient comes to me with a clearance, a central clearance of 1,000 micron, maybe. It's huge clearance in the center. There's no need to leave all that much clearance. And when I ask the patient, how does it feel? It feels good. However, their complaints would be, the minute I remove them, I'm getting a lot of rainbow effects. So we're talking corneal edema.
Of course.
They blur out throughout the day. They blur. I have to remove them, fill them up again. And so every 2-3 hours, they blur out. Well, there's too much clearance. So listen to other complaints so you can tell exactly what could be the reason.
Exactly. Remember a few years back in Dubai when we were discussing about ischemia under sclerals, we all thought in the beginning, oh, sclerals with the new RGP materials, they will be the solution to edema. Then no, too much clearance would cause edema. So I think this is something, please just remind us of what we should do regarding the clearance, please.
So you have to shoot for during, as I said, in the first 30 minutes of the exam, you need to shoot around 4,000 microns of clear, which is not 4,000, 400 microns of central clearance. So 400 central clearance, it will drop around to 300, 250. So if you are left with around 150 to 200 microns right in the center, that is better for oxygen permeability, that is better for midday fogging, that is better for many things. The other thing I want to talk about, this is one of the problems you will see a lot with scleral lenses, is the midday fogging. So there are a few solutions for that. First of all, change the filling solution, switch from saline to a more preservative-free eye drops, like anything that is for dryness, refresh drops, anything that you can use as a preservative-free. Those things they do fog less than the regular normal saline. You need to make sure that there is no much clearance. Every 8 hours, ask the patient to remove the lenses, clean them up, and put them back. That really helps a lot.
Excellent. Talking about caring about them, what type of contact lens solutions you recommend for caring for scleral lenses?
Well, there are certain contact lens solutions that is made specifically for RGPUs, where the lens, if you put it on your finger, you will see that it's a little bit thicker, more viscous. Those are made for scleral lenses, for RGP lenses. However, they're not easy to find. I mean, sometimes they're available, sometimes they're ran out, they're missing, they're not in the market. We start looking for them, trying to get them from different channels. They are not there. And at this point, I tell the patients, you can use soft contact lenses as a temporary base. So with the soft lens solutions, you still can get the disinfectant power. You can still get the cleaning power of the lenses. So, but I do recommend choosing the contact lenses, the solutions that are made for RGP lenses. This is one kind. The other kind, if you really don't have them or they're missing or whatever, you can use the hydrogen peroxide based solution as your daily contact lens solution, and it's wonderful. They disinfect your lens. You feel that they refresh your contact lens use. They're good. So basically, soft lens solutions, RGP lens solutions, or hydrogen peroxide based contact lens solutions. I don't use any cleaners anymore.
Cleaners, yeah, that's the question about cleaners. What shall we do?
We don't use cleaners. There's no need. There's no need unless the lens is really very filthy and there's a lot of like oily deposits. And basically, I don't use them because rubbing the lenses does the job. You don't really need to go to a cleaner.
Yes, actually, also during the Global Specialty Lens Symposium, which happened in Las Vegas a month ago, they also said if you don't have cleaners available or your patient is not a heavy depositor, you can use hydrogen peroxide-based solutions like once a week to have like an overhaul cleaning effect. They do the same job.
That I always, hydrogen peroxide solution, I prescribe them hand in hand with the RGP lens solution, because I tell them Well, use your RGP lens solution every day, but
Mhm.
at least once or twice a week, throw them in the hydrogen peroxide solution. It will,
Mm.
you'll do something good to your eyes if you do
Of
that.
course. In talking about handling lenses, especially in the Middle East and the Gulf region, you know, the weather in our countries, especially with the dust and everything, are still sclerals fine to be used during these weather conditions, or we just have to move to Europe to use them? That was one of the questions.
Well, I mean, I swear, scleral lenses already helped with this problem. I mean, they
Right?
are covering half of your eye opening, not allowing any particles or dust particles to get inside, not allowing wind to get inside, not easily popped off the eye. I think it just it did the job. I'm pretty
Exactly.
much.
Yeah, my humble experience with scleral lenses for over 10 years now, it just saved me lots of troubles, to be honest with you.
Yeah.
And one of the issues that we had sometimes with ill-fitting RGPs is the drooping of the eyelid. That's one of the cases that one of the attendees asked me. And what shall we do to remedy this? Because they wanted to go off lenses forever because of that issue. What is your
What
recommendation for
what
that?
kind of lenses are they using?
Small diameter RGPs, and they're
Yes.
complaining of drooping of eyelid, and they just want to get off lenses forever.
Well, this is one of the side effects of corneal RGP lenses. I've
Of
seen it.
course.
It happens. It happens. Yes. If you switch them to sclerals, you will, because of the lens size, I have seen that the opening of the eye, the fissure, improves a little bit. It improves a little bit with those lenses. What
Indeed.
happens with those patients who are corneal RGP users, because of probably discomfort or having this fear of that they're going to lose their lenses if it will pop off their eye, you try to squint so much with those lenses, so the overall look of them, they always have a very tired, droopy eyelids. The
Mm.
minute you open it up with those clear lenses, they just feel better. I've heard feedback from the patients saying that I feel my eyes are getting bigger. I feel like my eyes are growing, or they're feeling better and
Mm.
bigger. So you can try switching them to scleral lenses, and I think they will do, unless there is some kind of muscular problem where it costs. I mean, there's a ptosis issue now, and
Yep.
I've seen a couple of cases like this, that they started not having only droopy eyelids, they start having ptosis. Then stopping using those lenses for a while might improve it, but in certain cases, you probably need a surgery.
Indeed. 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 Um, Very interesting question. Have you ever fitted a patient who has epilepsy?
I try to really make sure I don't prescribe contact lenses for mentally not developed mentally patients or patients with seizures.
Mm.
Well, epilepsy, depending on how severe the case, I haven't really fitted once, but I don't see why not. I mean, again, what I'm really worried about is if he had a seizure or something, if the lens is going to pop out of their eye, or something like that. But with scleral lenses, again, probably it's not going to be an issue. And for epilepsy patients, they are not always in seizure. However,
Indeed.
I totally avoid fitting them on a mentally retarded patients
Sure.
who cannot be under supervision. And I've had some referrals for Down syndrome patients, because we
Mhm.
know that is very prevalent in Down syndrome to have keratoconus
Indeed.
and really corneal irregularities. I try not to do that unless there is a great big supervision of the parents. They are the ones who put the lenses on, they're the lenses who care for the lenses, but definitely not for the patient himself.
Indeed, I totally agree with you. Anyway, we're almost towards the end of our session. Thank you so much, Dr. Bassima. We really miss you. We really miss those face-to-face live meetings that we used to have. Amjad. Oh my God.
It's been really good days, golden days, I call them. But inshallah, things will go back to normal. The past 2 years with this epidemic, it separated everybody. We haven't seen people other than online and on Zoom, but definitely we're looking forward for more meetings in the future, more courses, more contact lens fitting courses. And I really want to thank you all for attending. Thank you for, as I said, leaving your weekends and staying with us. Thank you, Dr. Amir, for being with us also. Any other question, anything?
I think we're fine with the questions. Please بدنا أمير بس هيك ينهي لنا السيشن since he's the host of this meeting. But I think I was reminded to inform everyone في questionnaire انبعت لهم بالإيميل. يعني the organizers would really much appreciate it إذا هن قدروا to fill that questionnaire if possible. Amir, do you like to say anything for the audience قبل ما نسكر? I think our role is over.
بس بدي اقول ثانك يو لدكتور باسمة ولك، وبدي اقول لك دكتور باسمة الكومنتس من لبنان عم تجي انه كثير حبوكي، فهيدي مش اخر لكتشر رح تكوني معنا.
Great, and I can see the thank yous that is in the chat box. There's a lot of thank yous.
عن جد يعني تليفوني ما هدى من اول المحاضرة. وكمان ما بدي انسى انه ارجع اشكر مرة ثانية وثالثة مستر احمد طيري رئيس الامكو على هيدا الدعم يلي عم يعطينا اياه لهيدي، وبدي بارك لك دكتوره باسمه بالجمعيه السعوديه على انك صرتي عضو بالهيئه الاداريه الجديده. يعطيكم الف عافيه.
We're working hard to make things better for optometry. inshallah.
ان شاء الله. Thank you للجميع.
Thank you so much.
نشوفكم الاسبوع الجاي بالمحاضرات القادمه ان شاء الله.
Inshallah. Good night everyone.